Hey guys, it's Em here from the Pelvic Hub. Welcome to our very first live for 2020. I am really excited to speak today with Heather Jeffcoat, who is a pelvic physical therapist based in the Los Angeles area. She's the author of Sex Without Pain, a self-treatment guide to the sex life you deserve. And she's the owner of Femina PT and has 3 clinics in the greater Los Angeles area. And today, as you all know, we are going to be talking about the impact that, sorry, I'm just letting her come on, that the impact that cancer treatments can have on the pelvic health, and actually what a huge impact that will be. So we are going to be starting with a bit of a case study so that you can see and kind of just a woman's experience after cancer, and then we'll be answering some of the questions that you all kindly wrote in about. So hopefully, hey Heather, how are you?
Good, how are you, Em?
I'm good. Thank you so much for joining us. We had lots of really great questions from a variety of cancer survivors, actually, from breast cancer to ovarian, bowel. It was like a really broad range, which highlighted the need for talking about this stuff. So thank you so much for joining us.
Thanks for having.
Yeah, so I thought as we spoke about quickly, I'd start by just reading a bit of a case study, and then we can go from there. Does that sound good?
Perfect.
Okay, cool. So, and this woman has given us permission to share part of her story as well. So she said, I'm 49, have 3 kids, and am in a long-term relationship. I finished 5.5 weeks of chemo radiation for stage 3 anal cancer 1.5 years ago. I was given a set of 4 dilators, but was unable to use them until 3 months post-treatment due to a severe skin reaction. I have been using dilators ever since, 2 to 3 times a week, although sometimes I lack motivation and miss a few weeks. I've managed to get to a number 3, and my oncologist says I should be able to have sex. We have tried. The entrance to my vagina has narrowed. The most my partner can get is about halfway in, and then I stop as it's painful. It feels tight, like something might tear. I am really relaxed and reluctant to try. I am happy to talk openly, but the medical professionals here don't. The only people who understand are the patients I have connected with. I am also in radiation, or radiation has also put me into menopause, although I'm not noticing many symptoms, but I have 0 libido. I have asked to be referred to a pelvic floor therapist, and I wonder whether I'll ever be able to have sex again and worry about the impact on my relationship. There is very little intimacy as I have no libido and worry about trying penetration. So this little case study, this few lines, I think really brings up a lot of issues that cancer survivors face after cancer. And obviously a big part of that is pelvic floor and pain. And I think it's super confusing just generally about what we should be doing for pelvic health, whether or not it's strengthening and how we're strengthening or down training and what we're using. And so I was hoping that you might be able to start by speaking to, specifically in pelvic health after cancer, what is your experience in, I guess, the pelvic floor?
Yeah, so, typically the majority that of diagnoses I'm seeing, at least in my practice, are more pain-related, scar tissue-related, stenosis, which is narrowing of the vaginal canal due to radiation. It could also be muscular, so it might not just be like scar tissue or mucosal, like can happen mucosal changes with chemotherapy, but you can get muscle guarding around areas of pain. So it's got many layers to their pain beyond just like the scarring or what's happening at the tissue level. There are many women that will go into menopause, essentially medically induced, and it doesn't even have to be because they maybe had a hysterectomy because they had cervical cancer. They can go to menopause after they have breast cancer, and then that really confuses like some women when that is not discussed with their provider or discussed by their provider, and they might think menopause, but they're not sort of talking ahead at what that means related to their sexual function. So I'll see a lot of women after breast cancer that experience pain, and it's really more so due to the vaginal lining sort of thinning that happens when you're low estrogen and it becomes more irritated. But when you have any sort of irritation or pain in any area, no matter where it is, you guard your muscles. And so when I explain that to patients, you know, like if your back is hurting, your back muscles are guarding. If you have, you know, whiplash, which is a ligament injury, like your muscles guard in your neck, like muscles guard around areas of pain. So it's not just a matter of adding lubricant to help with muscle guarding. You really have to work on down training the muscles, which essentially means that you're not teaching them to do Kegels. You're actually teaching them more to relax and stretch the muscles, the tissues, the fascia in the area before strengthening.
Yeah, that was one of my the questions around Kegels that came up multiple times through the questions that we put up on Insta. And I guess the two main questions around the Kegels were, you know, do they need, is it going to help if they get like a pelvic floor trainer instead of just doing Kegels, or should they be doing you know, core muscle activation because it's going to be impacting their pelvic floor? So can you give us a little bit of guidance in your opinion on what you do around that?
Yeah, and I just want to clarify actually something, just like culturally, when you say trainer, do you mean like dilator or do you mean like a Kegel trainer?
Yes. Okay, that's a very great question. I actually thought about this myself. So I know that in the US that dilators can also be called trainers, but this question, this is an assumption, but it's not very common in Australia to know that a dilator can also be called a trainer. So I'm assuming that they're meaning the kind of feedback stimulating type device.
Okay. Okay, thank you. I just want little, you know, differences in
big
across the ocean. So with most of my patients, like if they have pain, they're not starting with biofeedback training to help isolate Kegels, do better Kegels. They're usually, if I use biofeedback at all, I'm using it to help them to relax the muscles, getting them aware of if they're gripping and holding. But I tend to honestly not use biofeedback therapy too much. I do more manual therapy and instruct in dilators because I just find it's just more effective with the time I have. You know, it's just, they can gain awareness through the sensory input I'm providing, and then I can teach them how to use the dilators at home. And I just find that that's a lot faster route for them to meet their goals than using a machine in office that they don't necessarily have to take home. And, you know, I'm all about like establishing a home program very early on. And so that tends to be my preferred path. Now, if they're having incontinence and they're not having any pain, because incontinence can be a side effect as well, you know, especially with more pelvic type cancers, depending on what's removed, you have those anatomic changes. It can change the angle of the urethra. If it is more of a pure weakness and incontinence is their primary concern, and I don't find that they have an overactive pelvic floor that might be creating their incontinence, then I might do some up training with biofeedback.
So it's really important that they don't just go and they really need it personal.
Yes. And you know, just because somebody has leakage, yes, they're weak, but it doesn't mean that they need to start strengthening. So in my office, and I wish I'm at home now, I wish I would have brought it, but if anyone just Googles length tension curve or the length tension relationship of muscle that's watching this right now, then it'll explain why, yes, if muscles are overstretched and long, they're weak, but it also very visually shows how if they're short and tight, how they're also weak. And if a muscle is short and tight, you don't want to do Kegels and a lot of strengthening because you're just going to make it shorter and tighter, and it's going to continue to stay weak. And in the case of somebody that has pain, that yes, you might find that they're weak, but strengthening is not the answer. Again, it's stretching, releasing the muscle and the tissue prior to initiating a strengthening program.
Yeah, especially if pain's still there, to continue that sort of up-regulating guarding at the same time. There's not there's not much hope. So, yeah. Going back to the, how you use dilators in the clinic. So can you talk to us about sort of what you look for in a dilator, how you use a dilator, and how you then empower your patients to then be able to continue their treatment at
Yeah,
home?
so if they're having, or if they present with an overactive pelvic floor that's contributing to either, and I say leakage, but it could also just be urgency, like urinary urgency and frequency without leakage, or other kind of pain like sexual pain, then the first thing I want to set them up with is, are they appropriate for using dilators? Like, I want them day one to go home with a set of dilators so that they can do the exercises that I teach them and get them towards their goals. So I tend to use a mix of rigid and silicone dilators. Primarily, typically in my office for non-cancer related, I prefer rigid dilators because the techniques I use are really getting at like movement and stretching and massage. And when you have like the smaller silicone dilators, they're just too bendy, and it doesn't really work well for the techniques that I'm teaching them. Like a gentle trigger point release, like very gentle, always going from a pain to a pressure, never creating more spasm or guarding as I'm doing the release. Doing neuromuscular stretching, like a contract relax, a perineal massage, and some other like internal techniques with movement. So I prefer that to be with like a really small, like finger width, but longer handled rigid dilator, so that they can do those techniques, and I call that their warm-up program. And then when they get to larger sizes, then we move to silicone because it's just softer and more comfortable. And when you get to the larger silicone dilators, they tend to not really be as bendy anyways, just because they have so much thickness to them. So, so I tend to transition more to silicone in the cancer population. I'm also, worried too about the like sensitivity of their skin, and sort of how good the quality is. So I'll always double check with the surgeon, how aggressive can I be? And I figure if they're cleared for intercourse, I can probably be pretty aggressive.
Yeah, that's
because anything I do is not going to be
activity for sure.
Anything I do is not going to be more aggressive than sex. So, so I feel like I can, but I just always, want to go over my techniques with the surgeon if it's not one that I've worked with before, and really just make sure that the tissue quality is good for me to work on that. And to the point of the case study, the woman, because in case she's here listening, I want to sort of say to her that it's interesting that she said she was on her third dilator and her physician said that sex should be fine. However, she says her husband's closer, like between the 3 and 4. So I always tell my patients that it probably will hurt until you get to a dilator that's the same size as your partner. Yeah. So, I would say, well, of course you still have pain, but she's so close. Like, I feel like
she's so close, and she's been consistent as well for this whole time. So I just want to give her she's there. I think she might.
And a lot of ways dilators are taught are the way they're listed on the box. Like even the rigid dilator set that we use in our office says insert and hold for 10 minutes. And so the approach that I do is more active. It's basically various kinds of intravaginal massage techniques and scar tissue techniques as well, if there's scar tissue. And it's just, I think, a more active approach to that, treating it like I would treat any restricted tissue, scar tissue, any restricted muscle. It's not a passive insert and hold. That to me, that's not very functional. No. That's not how we stretch any tissue. I tell my patients, if your hamstrings are tight, you don't just bend over and stretch your hamstrings for 10 minutes. Like, that's not what we do. We have like periods of time, we do multiple reps, go back into the stretch. There's manual work that can be done, but it's never just a like stretch and hold for 10 minutes.
That's exactly dynamic. The body is like not sedentary and just things like that. So I
saw someone come up with a question. What dilators do you recommend? So typically the silicone dilators that we use here are sole source dilators, medical grade silicone. I like them because they're very soft and they are just smooth, very easy to clean. Like there's no grooves or bumps to, try to clean around. So they're also a made in the USA product, which I try to support. And I think for a lot of people, it's important to support that. So they are actually made in Southern California, where I am too. So it's a great company.
Yes, Soul Source and small Jane and Lloyd are a wonderful couple as well. So going back to the the way that you instruct the dilators. It's interesting for me talking to people in Australia. They get a variety of different information around how to dilate, like you were saying. But in terms of your treatment, how many times per week, giving people kind of like a treatment expectation? So say, going back to the case study, if you were to see this woman, what would it look like? How often would you see her? How often would you be wanting her to do her home program? And what would you sort of expect given what you know about her so far?
Yeah. Yeah. Most of our patients come in a minimum of once a week. If they're able to, between like finances and schedules, we encourage most people to come twice a week, because then, we do this all the time. We're just more skilled at getting all the releases, even though we're trying to empower patients with a dilator. Yeah. Program at home. Like I might have 8 pelvic floor patients back to back in a day, multiplied by, 4 to 5 days a week times almost 20 years I've been doing this. Like it's the pretty rare patient that feels like they're mimicking 100% of what I'm doing. I'm really happy if patients feel like they are mimicking 50% of what I give them. And I'm like really happy with that. So that's like one expectation that I set for them. The other is that I want them to be using the dilators as often as their body allows them to use it, but no more than once a day. So everybody is different. I tell them there's not a standard rule of thumb for dilation therapy. Some people will do great dilating once a day. They're not sore in between. Other people are sore after, so they need to take a day off. And so if that person is like, doing more is better, I'm just going to push through this, then they're just going to be creating more muscle guarding and, or is it the sensitivity of the tissue? Like they're not going to be pushing themselves ahead. They might actually be slowing their progress down if they don't let their body rest. And then I have some patients that can do 2 days on, but the third day is just too much. So they're like 2 days on, 1 day off. Yeah. So I always prefer my patients err on the side of like, start doing every day, once a day, and then only cut back if your body is telling you that it needs a rest.
Okay, perfect. So she
might not be doing it often enough in that case study that you brought up, because her body might be saying I can do more, and if she's going every other day, then just think of the muscles and the tissues that are involved. It's like if somebody is tight, what do we do for PT? We don't tell them to stretch 3 times a week if they're significantly tight. We're telling them to stretch like every day, multiple times a day. But I feel it's a bit much to expect somebody to bust out the dilators twice a day. And I've had like a couple really motivated patients do that, but I don't think it's necessary to do it more than once a day.
So in terms of, obviously there's this gap between you finish your treatment and you have side effects and symptoms, and then you've got the outcome of getting functionally better and reducing your symptoms and improving. And I know that usually the gap, obviously with this lady, it's been 1.5 years, so she's still really motivated for that time. But are there things like, going back to some other questions I got asked, are there exercises in terms of core strengthening they should be doing or avoiding? And then also, in terms of getting back to sort of any form of intimacy or being able to, not completely avoid, do you have any recommendations around reducing pain or anything like that, so that they can start to kind of improve that side of things while they're improving all of their pelvic floor health and everything with a physical therapist?
Right. So I do often refer out to sex therapists to help address the intimacy aspect. But if a woman's not experiencing clitoral pain and she, is okay with maybe using vibrators or even manual stimulation with her partner, I would encourage them to do that while they're waiting to progress towards penetrative intercourse. So that would be a big recommendation that I would say, with just keeping things intimate and just really establishing rules around that there is no attempt at penetration of any kind. Yeah. So that there's no fear of it going too far, just that's all established in, on the onset. Let me see, what else? What was the beginning part?
Around the like any form of, because how exercise is obviously so important for our health, and especially after cancer, and then I guess the impact that the exercise you choose would have on
the pelvic floor. Okay, yeah. Perfect. Sorry, I lost track of my thoughts.
There's a lot of questions.
Yeah. So yes, most types of like cardio exercise are really any type of cardio exercise I'm okay with. Maybe not spinning if they're novice, because I would be concerned about just the seat on the pelvic floor, possibly like irritating if they've had radiation, but any other types of cardio they're comfortable with, I would encourage. I tend to want to have them stay away from doing hardcore Pilates or a lot of core strengthening if they have pelvic floor overactivity, simply because a lot of, like your deep abdominal muscle, which I know, but like the people watching might not know, an internal corset muscle called your transverse abdominis that works with your pelvic floor. So, and they mention that a lot, they cue that a lot in Pilates. So if your pelvic floor muscle is already holding tight, you don't want to be contracting other muscles around it, and other like hip muscles that'll facilitate like a tighter pelvic floor. So I have had to tell some patients to stop Pilates. But then, we try to resume it, especially if they're coming to PT even like twice a week, if they're not doing a home program, or if they're coming once a week and they're doing their home program at least a couple times a week. Then I want them to also feel like they're psychologically getting back to the activities that they love. So, I do try to meet them in the middle. But the Pilates isn't, I don't know if you guys have it in Australia, but there's like a really hardcore Pilates here in the States called Pilates Plus, and it uses something called a megaformer, and the classes are the hardest I've ever been to. Not being injured, I feel injured every time I leave from it. So, and I'm like, and I know what I'm doing, and I'm Pilates certified. I'm like, this is so hard for anybody. So I wouldn't want somebody going to that kind of Pilates, but like a beginner level, if they want
personalized Pilates approach while you start, and rather than going into a big class and kind of just doing what's good for sort of
like a one-on-one where it can be more like beginner, but just the patients need to understand that not jumping to a lot of like core strengthening right away, and why I'm delaying, because I'm just trying to really get the pelvic floor to calm down in the early stages.
We just had a question before about the difference between, to explain the difference between a physiotherapist and a pelvic therapist, and that's just it's just a different terminology for a similar role. In Australia and New Zealand and the United Kingdom used physiotherapists, so does and then
Canada. I think honestly the whole world uses physiotherapist, and the United States is just like, we're going to call it physical therapist.
So there's
it's the same thing.
Term.
but to that point, it's also really really important to understand that physiotherapists and physical therapists, we're the same sort of degreed licensed profession, and we have to be licensed in the state or the country. I don't know how you work it there, but we have to be licensed, and we have a board that we answer to, and we have to renew our license. And there are people out there called pelvic floor therapists that do not have a license, and they're trying to practice this type of therapy, but that is not the same as a physiotherapist or a physical therapist.
Well, we haven't come across that yet over.
Unfortunately, we have. So that's just something to really be wary of, and understand that you do need to see a licensed provider that has an actual degree, and has taken a lot of continuing education courses as well. A lot of additional training beyond, we don't learn this kind of stuff in school. So
that's the same as this, that you need an extra lot of qualifications to be specialized in the women's health field. So you definitely have to seek out the right practitioner to get the treatment that you need. And I'm sure if you DM Heather or DM myself, if you're looking for a pelvic therapist,
we know people all over the world between us.
Yeah, we can definitely link you to a good person. So just really to follow up, it looks like we've covered so many of the questions, where there's a lot of questions around scar sensitivity and pain, but I feel like that's a whole topic in itself. So
but we can work on that manually as well to desensitize the scar tissue. Again, like for anybody that's watching this and is trying to just sort of grasp like why they are having pain. Think of first the muscles, and that muscles guard around pain. And this happens to everybody. It's just unfortunate that when they're in the pelvic floor, a lot of providers just seem really just lost, and they just don't really know what recommendation to make. And they're not thinking of a pelvic physical therapist that is like the most appropriate provider to treat that, because we are muscle people, right? And we are scar tissue people. Like after someone has their knee replaced, we work on the scar tissue there. You know, once you have, you know, organs removed or, you know, there's any scar tissue that develops, physical therapists should be the one working on that. Like that's our profession. That's all we do. It's just in a specialized area.
And sometimes I just want to add on the scar front that sometimes you have the hypersensitivity and the awareness that that scar is actually causing you pain and symptoms, but quite often, from what I've heard and in my own experience, these scars can just sit there and you think that they're not causing any issues, but they really also still need to be addressed. So again, it's great to have the whole thing looked at.
Yeah, and a couple of important points on scar tissue too is, you know, they can continue to retract for a couple of years. Like if you think of like the hysterectomy scar across the lower abdomen, which is like very similar to a C-section scar in location. So those scars can continue to remodel and can get tighter, maybe more like drawn in. So we can work on the external scars as well as internal scarring from like stenosis from pelvic radiation. From radiation, that can last for years. Like I think I heard 20 years that radiation, post-radiation stenosis is still a process that's happening. So, you know, this woman in the case study that was using the dilators for a year and a half, like she's going to be using the dilators as long as she wants to maintain like her sexual health. But even at a minimum, she needs to continue her dilators so that she can have her pap exams. And, you know, it's unfortunately the effects of radiation are very long lasting. And a lot of patients that I see don't come in with that knowledge either. So I think providers aren't setting up that expectation.
Yeah, that there's not a quick fix. But also, would you say, Heather, that once they get to a point of being able to, and they want to be, and they're sexually active, that sort of is almost like obviously helping, so we won't need to dilate as much if you can get to that stage? Is that
right? It would be more of a maintenance program. Like you wouldn't need to dilate every day, but you know, you still need to check in on yourself if you're not being sexually active. If you're sexually active, you know, on a regular basis, like even once a week, I think that that's enough for you to check in and be able to tell like, ooh, things aren't feeling as like good as they used to feel. I'm starting to have pain. Then you would need to maybe increase your dilator frequency for a short term, but you can't just meet your goals and then have really infrequent intercourse and expect that it's going to stay, because the radiation effects are ongoing.
Yeah. So
then I'm talking pelvic radiation, but
this actual local radiation to the pelvis. So I guess I'd love to, I know that it's a big management thing, and it's good to also know that you need to constantly sort of check in with yourself. But I'd love to finish with a bit of a feel good around how good pelvic physio can be for after cancer, the side effects of cancer. So do you find that the majority of your patients in clinic end up, you know, with their quality of life improved and most of their symptoms either managed or better after a period of time?
Oh yeah, improvement for sure across the board. You know, how much improvement really varies from patient to patient. The earlier they get in, I find the better the outcome is. So if someone's several years post just seeking treatment, if they've had like pelvic cancer with radiation, then they might not reach their optimal goal. But if, you know, the sooner they come in, the better. But I would say that's not the case with breast cancer. When I've had women that come in and it's more related to like menopausal changes. I mean, really, it's like I'm treating a menopausal woman, even though they are young, because it was medically induced. They might be years out, and I can still get them to pain-free because there's not any sort of like structural changes.
No scarring,
in their anatomy, no local scarring. There was no radiation to that area. It's just like treating someone in menopause. And a lot of times, you know, so they're told to use lube, and they're told, most of the time the oncologist doesn't want them to use estrogen, and the gynecologist wants them to use estrogen. So there's that like huge struggle there, but at the very least they're using lubricants and, you know, along those lines with menopause, they experience pain, and so it's muscle guarding. So the only thing I'm treating at that point, honestly, is the muscle overactivity. So they usually go on to pain-free intercourse in that case.
So I guess the most important message is that if you are having symptoms after cancer and you haven't been told, that it could be from treatment. Or I had a friend who was just like, oh yeah, it's just from the treatment. I just have these, you know, hot flushes and everything, but they weren't really aware that it can have an impact on your pelvic health. So it's really important to, I think it should be mandatory to go and get a pelvic health assessment after.
Yes, and you're going to need lubricant, and look at your lubricants, because you want to make sure that, one, if you're using an oil-based, that you are not using those with condoms, because oil-based lubricants will reduce those efficacy. And you want to look at like that you're not using parabens, because those can mimic estrogen in the body. So if you have an estrogen dependent cancer, you want a paraben free lubricant. So that's really important to understand. So so that'll be helpful, like big lubricant tips.
Oh, sorry to interrupt you. I do have if people are interested on the sort of I made a lubricant checklist that hopefully goes through sort of just as in like when you're shopping for a lubricant, what you can look for, and some of the names that are sort of like hidden nasties, sort of like how sugar is in our food a little bit.
Oh, you have that on your blog?
Yeah, I have a little list just so that people can go and look and take a look at what they're putting in their bodies. But I saw that you recommended when we did our interview, you were recommending in your clinic you use liquid, and what was the other one that you use?
Well, we used a lot. I forget which one I said in your blog.
Oh. Okay. Well, you can look at what Heather wrote in our blog. But I'm sure, and if you want to learn anything more around Sex Without Pain, you can obviously go and check out Heather's book, Sex Without Pain, A Self-Treatment Guide to the Sex Life You Deserve.
I have one at my desk. I'll show here.
Oh, yeah. So that's on, that's going to be a link on my website to that. That's available on Amazon. In the UK, you can buy it from Pelvic Relief, and then you can also buy it direct from Heather at this stage. So definitely worth the read. And thank you so much, Heather, for taking the time out. I'm sure we'll get a lot of questions after this, and hopefully we can chat again.
You can do a part 2, Em.
I think we should do a part 2. I feel like there is just such a huge amount that we could cover and talk about. So if any of you have any questions, just DM me or Heather, and we'll work on trying to continue to raise awareness and get people to the wonderful practitioners they need to improve their quality of life.
Sounds amazing.
Okay. Thank
Bye.
you so much. Bye.